MRD is playing a key role in many conditions. I mean, ALL, obviously, AML also plays a role in CLL, in hairy cell leukemia, in chronic myeloid leukemia, obviously, so in most conditions. In lymphoma, this is less used so far, but you can monitor that. And then the follicular, you can monitor the BCL2, and this is certainly doable. It's not approved yet. But even in CLL, it's not approved. Even CLL is an indolent lymphoma. Although in all trials MRD is utilized, it's not, however, recommended by the guidelines yet. So this means to say that in CLL and in follicular lymphoma, MRD negativity should not so far be an endpoint of treatment. Having said that, it is clear that if you do become MRD negative, both in CLL and follicular, patients tend to do better. So I think on the long run, this will probably change. And the other point that we've made in some of the presentations, and I'll be discussing, I discussed this recently too somewhere, is the fact that the tools are changing. This in general, MRD is changing. From quantitative PCR, we're going to more sophisticated technologies, namely digital droplet PCR, and there's also a lot of interest now in the so-called liquid biopsy, which in lymphoma could be informative because obviously lymph nodes may have a more heterogeneous genetic landscape, and the plasma could be more informative. It is, in terms of genetics in lymphoma, mostly high grade, I must say. And now there's a lot of investigation going to see if liquid biopsy could also be utilized to monitor MRD, but that's still a research question. So the bottom line is that it probably has a role, and it's seen in most studies that MRD has a role, but it's not approved yet. So that's still considered partly experimental, though I think it will probably change in the near future.